So today I'm going to present the results and the methodology used for...
It is on.
Is it on?
Yeah.
Okay. Okay, so today I'd like to present the result and the methodology used for setting research priority on newborn health.
Can't hear, it's not on.
Okay. It is on.
It is on. Let's bring
Okay,
it
I
up.
have to. Okay. So today I'm going to present the result and the methodology used for setting research priority on newborn health and birth outcomes. Okay. So this was a collaborative efforts between WHO, Saving the Newborn Lives, and UNICEF. The steering committee members has included Jose Martinez, Rajiv Bal, and myself from WHO, and then Joy Long and Steve Wall from Saving the Newborn Lives. We have also consulted two people from the University of Edinburgh, Igor Rudin and Harry Campbell, for the methodological expertise and advice. First of all, why are we setting research priorities? We know that more than 130 billion is spent for health research each year, but in spite of this, we know that the amount of proposals for health research funding exceeds by far the available resources. We also know that funding does not always correspond to the disease burden. It does not consider the disease burden nor the country priorities, and it is often driven by political consideration or donors' priority. Speaking about newborn health, we know that donors' attention on newborn health has increased substantially since 2002, but the extent does not commensurate with as much as 3 million newborn deaths, which is as much as 43% share of under 5 mortality. So there is clearly a need to guide limited research capacity and funding to get the maximum impact on mothers and newborns. And increasingly, there is a need to set the research priority in a fair, transparent, and systematic way that would take into account the disease burden and implication for equities. Having said that, we have some successful examples of setting research priorities. In 2007 and 2008, we have carried out a 5 set of research prioritization exercise on 5 major causes of under 5 mortality using CHNRI methods, which I'm going to explain later on briefly. So this 5 prioritization exercise has coincided with a subsequent increase in the number of scientific articles, and then funding and investment, and also more requests for funding in the priority areas that were identified in this 5 set of priority exercises. And with the expanded mandates of the department in WHO, we needed to identify and articulate the research agenda, which is beyond 2015, and not only on survival, but also on health, growth, and development. So considering all these benefits, we have initiated the process to set the research priority on newborn health and birth outcomes as part of the broad exercise. Next one is what was our scope for setting research priorities? So our motivation was to improve newborn health and birth outcomes for the next 10 years beyond the MDG goal. The domains of question, we had 3 domains of questions. One is discovery. Discovery in a sense that the research question is suggesting the development of new interventions using novel technology. Second one is a development question using the improved or modified interventions to reach more targets. And delivery of existing intervention is categorized as a delivery question. Our population is newborn and stillbirths. Our focus is improving survival and health and growth and development. The timeline is 2013 to 2025. The audience included governments, researchers in low middle income countries, and international donors. Okay. Oh, excuse me, I forgot to press that. Okay, so this is the CHNRI methodology that we have used. It has 6 steps. The first step, we have formed a co-working group. We have defined the context and the priority criteria over a number of teleconferences that we have held among the steering committee members. And also, I forgot to mention what CHNRI methodology is. So CHNRI stands for Child Health, Nutrition and Research Initiative. This is the methodology developed for setting research priority in a transparent and systematic and inclusive way. The second step that we have followed is to identify and contact a large proportion of experts. We have identified 600 experts with researchers and program expertise. So 200 of which were systematically chosen most productive researchers with the highest number of publications for the past 5 years. We have also approached 400 program experts that were all listed in Healthy Newborn Networks. So previous exercise in 2008 were done with a limited number of experts in a rather exclusive way. So therefore, what we wanted to make sure this time is that the process is inclusive and to have a good balance of expertise. So subsequently, we have sent an online survey asking them to contribute maximum of 3 research questions. And of the 600 experts, we have received a response from 132 experts, which resulted in the generation of 390 research questions. The third step is that we have organized a 2-day meeting in September last year, and then we were able to trim down the research question from 390 to 205 by refining the question, reviewing the question, and addressing the qualities. And in that meeting, we were able to get the scoring from the 15 experts. And subsequently, we have contacted 600 experts again to get the scoring, additional scoring. And this is where we have received 77 additional scoring. And we have finalized the calculation of research priority scores. And today I'm standing here to present the result. Okay. So who are the people contributed in research ideas? These 2 charts shows the self-classified background of the respondents and also self-classified institution or organization of the respondents. So as you can see from here that we had a good balance between researchers and program experts among the people who generated the research ideas. 60% are researchers and 40% are self-classified program people. And also geographically, we had a good representation. 50% were based in low, middle-income countries in Africa, Asia, and South America. And the remaining 50 were based in high-income countries. Okay. This is the characteristic of 92 experts who scored the final list of research questions. So we were also able to maintain the same balance between the researchers and program experts for the 92 experts who scored the research questions. This is the scoring criteria based on the CHNRI method. Normally, CHNRI method recommends to use 5 research criteria that are all listed here. The first one is answerability. Can the proposed study be designed to answer the research question to reach the proposed outcomes? The second criterion is efficacy or effectiveness. Based on the existing evidence and knowledge, can the intervention which will be developed through the proposed research be efficacious or effective? The third criteria is deliverability and acceptability. So taking into all the difficulty in implementation, delivery, infrastructure required, human resource required, local capacity and needs, is the proposed intervention deliverable and acceptable? The last one is the effects on equity. Would the vulnerable group be likely to benefit from the result of the proposed research after its implementation? Scoring, in terms of the scoring, we have used the score that will give the maximum discrimination. Yes being 1, no being 0, but in case that the people are informed about the subject but undecided answer, we have prepared the midpoint scores. this is how the research priority score is being calculated. So the research priority score is calculated based on the intermediate score. It is actually the average of the intermediate score that is calculated for each question and for each criteria. And this is a distribution of the research ideas across the critical technical areas. As you can see from here, that we had a very good distribution of the research ideas across the critical technical areas. Okay. And here comes the result. I'm going to show you the top 10 priority in newborn health and birth outcomes. Okay. So these are the top 10 priorities. I'm going to read 5 top 10 priorities. The first priority was to evaluate a simplified newborn resuscitation program delivered by trained health workers. Second priority was given to evaluate approaches to scale up health workers' skills in preventing and managing perinatal asphyxia. The third priority was given to evaluate simple clinical algorithm to identify newborn with signs of infection by community health worker. The fourth priority was to identify and address main barriers for exclusive breastfeeding in low-resource setting. The fifth criteria is to evaluate the training of community health workers in basic newborn resuscitation. So this top priority, the number 1, has received a priority score of 90%. And the expert agreement for this question particularly was 77%. That means that 3 out of 4 experts had scored in a consistent way. So the common theme identified were, in this top 10 priority, was the implementation research to improve the delivery of existing interventions, which are cost-effective, and also increasing the capacity of community health workers and including them in the programs. And the protocol within this program has to be simplified in order to increase the capacity of health workers and community health workers, and also increase the deliverability to end users. This is the distribution of the top 20 research priorities by technical area and by domain. So from the technical area, 1/3 was related to intrapretum related, and another third was on neonatal infection, and 1/4 was related to integrated care. We were caught by surprise because we found that only 15% were related to preterm births. And also, by domain, despite going towards 2025, we still found that the implementation research, mainly focused on delivery, was quite predominant. And thirdly, some of these priorities identified in this exercise are in agreement with the ones that were identified in the previous exercise, such as KMC, effectiveness of chlorhexidine for cold care, and simplified newborn resuscitation program, as well as intrapretum fetal monitoring as part of improving the intrapretum care. So using research priorities, what are our next steps? We wanted to make sure that this is not a one-time exercise that ends after having result. We have a strategy in dissemination, strategy in promotion, and strategy in keeping monitoring the impacts of the exercise. So our dissemination strategy will provide opportunity for funders to see the result earlier, so they will be well informed. We also have drafted a publication, a manuscript of the exercise, which will be published, which will be submitted to a high-impact journals. And our promotion strategy, we will keep approaching national stakeholders, governments, NGOs, and a medical research institute to generate their research interest, while we keep approaching donors and funders to generate funding opportunities. Okay? And our monitoring strategy, would include monitoring the impact of the exercise by monitoring the request for funding, research funding, and then trial registers to make sure that these priorities are addressed after this exercise. And now I'm going to hand over to Joy for her comments.